Hello, I'm Dr. John Kruse, and welcome to today's question and answer session. So, as usual, I'll remind you the information I provide today is for general informational practices. It's not specific treatment recommendations. I'm open to questions on the two videos that were released this week on ADHD in general or broader topics of mental health. A special reminder is that next week, I will not be here, so I'll be traveling. And as an alternative to being here live, we're suggesting redirecting people to the Reddit to provide feedback on what's working for you or what's not working regarding these Q&A sessions and the channel in general, or topics you'd like to see or other feedback there. So the two questions or two videos that were released this week was a new one on MAOI and one on Sunosi, which was just briefly re-recorded the sound or re-edited the sound, and that came out several months ago or maybe almost a year ago. So I'll summarize those two topics and then jump over to the questions. So the MAOI in ADHD is that monoamine oxidase inhibitors are boosting levels of simple monoamine neurotransmitters, norepinephrine, dopamine, serotonin, and particularly the norepinephrine and dopamine boosting, one would expect would be advantageous for many individuals with ADHD. And that seems to be the case, but the actual amount of data or research on specific MAOI and ADHD is really scanty. There's, I think, 4 studies were all I could find, totaling less than 100 patients, all done, or most of them done 20 plus years ago, and all looking at just one MAO inhibitor, which is deprenyl or selegiline. And one of the problems of using that is that selegiline's breakdown products, the major metabolites, are methamphetamine and amphetamine. So it's not even completely clear how much of their benefit that was found in these studies was due to MAO action or due to what they degrade into. In the US, the most widely available form of selegiline is, it is available as a pill, but the patch, MSAM patch, is what's being used for depression and marketed more heavily, and that should actually reduce the amount of methamphetamine and amphetamine that it's broken down into, but we'll go into that. And then the other precaution with MAOs is that there are some potentially dangerous interactions with other drugs that affect serotonin and with foods that contain tyramine. And I see Dennis has already asked one question about that. So I'll get to that in a second. The next other topic was Sunosi or solriamfetol, which is a norepinephrine and dopamine reuptake inhibitor being hopefully brought to market by Axsome. They have several studies that were published earlier, and they've been trying to get phase 3 studies published. As James Alexander has more recent information than I do, that their stock price went down because there's some questions about the statistical measures used in their phase 3 studies. Anyway, the preliminary data indicated that solriamfetol had an effect size similar to other non-stimulants for ADHD and lower rates of side effect problems than some of the other options. Whether it turns out to be better than something like Wellbutrin, which is also predominantly a norepinephrine and dopamine reuptake inhibitor, we will learn, and whether it actually gets approved, and who knows what's going to happen or not happen, particularly in the highly politicized. There's always been some amount of politics, and politics should have some role in public health measures, but in the current environment, it's not even clear whether basic science is respected or valued, and that makes the process almost completely a political one. So those are the two videos. I guess I'll launch into the questions. So James Alexander highlights some of the specifics of what people are thinking are problematic. I have not gone into those specific studies recently, so I can't comment. I'd say one thing that jumps out at me is it's a really high placebo response rate, or really substantial reduction in scores. Historically, depression, anxiety studies were marred by really high placebo rates, and ADHD studies tend to have much lower rates of placebo response. Those have been increasing over time, as historically the depression ones did too. So what that says at a larger level about the use of placebos in studies, we could try to get into. I'd say the data that was released prior to now, to my mind, provided a fairly convincing case that solriamfetol was effective for ADHD. Again, it's already approved for excessive daytime sleepiness connected with narcolepsy, connected with obstructive sleep apnea. It's possible that this may either delay, or sometimes when a drug's been delayed long enough, the company just gives up, knowing it can be used off-label. They can't market it for treating a given condition that it hasn't been FDA approved for, and the FDA does look closely at that. But so the other points, and I'm sort of skimming over what James Alexander wrote, is that some of the question is whether there is statistical significance, and there's certainly differences between clinically significant, which is there a meaningful difference for people, and statistically, whether we can demonstrate that this difference was with a high degree of likelihood, not just due to random chance. And often just increasing the number of subjects, or it could well be if they had used a different rating scale, they might have gotten differences. So I'd say with one specific study, I wouldn't freak out or focus too much on statistically significant versus clinically significant. If all the studies were that equivocal, then that's a concern. So part of my approach is again, you need to take it in the context of what we appear to know about what this drug is doing, what we've seen in other studies, both targeting ADHD or looking at ADHD symptoms in patient populations that were not primarily ADHD patients. I think it seems fairly likely that they've established this drug is effective. Whether that's convincing data for the FDA is another question. So Dennis's question, and I have to scan back through it. So hello, Dennis. Hello, James Alexander. I don't know. Thanks for being here again. Dennis's question is, with MAO inhibitors, they are blocking monoamine oxidase, which is one of the important enzymes for breaking down norepinephrine, dopamine, and serotonin, so that these drugs, or so these neurotransmitters, don't build up higher. Or in the case of tyramine, which is not primarily a neurotransmitter, it's a monoamine that you get through food. And if you have an MAO inhibitor, the levels build up anyway, and can trigger hypertension. It's actually the interaction between tyramine and norepinephrine that's triggering the hypertension, not so much the tyramine directly. So Dennis asks, why does COMT, C-O-M-T, catecholamine O-methyltransferase, not take care of the excess catecholamine load? And it's a good question. So there's more than one enzyme. There's another enzyme besides MAO that breaks down dopamine, norepinephrine, and serotonin. One of them, so usually both of these enzymes are working together. So why, if one isn't, even if one is knocked out, why isn't the other sufficient? And I most of the explanation I'll have is a simple statement that, empirically and clearly it isn't sufficient. So how much of that is whether it's not available in a big enough supply, or if if it's not available in the locations that it's needed. The biggest concentrations of SCOMT are in the liver. It's certainly present in the brain, but maybe we could think of it more primarily as a liver deactivating enzyme. Again, it certainly is there synaptically and present in neurons and astrocytes, but my answer is that it's not designed or geared up to be the primary clearer. It's a secondary one to MAO, at least at the neurotransmitter level. So I don't know if that explanation is good enough, but again, empirically, we know just looking, people wouldn't run into trouble if COMT was able to do the job. Before I jump into other questions, Larry Moose has asked a question a couple times. So another overarching comment is that YouTube changed how in the past I would get an email through Gmail every time someone commented on any of the videos, and I would try to go through all of them. Hopefully this channel gets big enough someday that I can't get through all of them. But starting, I think, on June 26, without notifying me in any way that I've been able to see checking back through my emails, it's not just me. They don't notify any creator about feedback. And there's a way to search for some of the comments collectively rather than opening up each video. But I'm only just figuring out how to use that. And so far, it does not even seem to be including all the comments. So I've been less diligent about getting back to comments put on this space. Hopefully I will develop a system that treats that better. Anyway, Larry Moose had a question that, can I address the struggles of people trying to seek treatment in this current medically strange, where access to medications and to doctors is difficult or challenging, and people with ADHD have a penchant for getting off track or getting distracted. The last few are my commentary or added in. What I would say is that in the US, and again, this is going to be different for each location. In the US, most people have some form of insurance, even if it's Medi-Cal, or California's Medi-Cal, which is Medicaid, or Obamacare plans. In the US, the insurers are actually required to have on their panel or in their network people who are there to treat any mental health problem. Whether that means you get a psychiatrist who doesn't know much about ADHD and knows more about other mental health problems as a potential problem. But again, starting with working through your insurance company is one of the usually most quick and efficient ways of finding a provider. And specifically, most of the larger plans do have, if you've called a dozen names on the list and they're not taking patients, you can ask for assistance from the insurer, and whether they call them ombudsmans or ambassadors or helpers, they will often make calls for you, which can help expedite who actually is taking new patients and who might have expertise in ADHD. My other general recommendation is CHAD, which is Children and Adults with ADHD. It's a patient-oriented, patient-started nationwide support system. They have chapters in every major city and many smaller cities across the US, and I believe some worldwide as well. And that may be one of the best ways to learn from other people who actually has expertise, because in this day and age, there are many people, providers, doctors, nurses, social workers, psychologists who write that they have expertise in ADHD, and at least some patients' experiences, this person doesn't really seem to know it or get it. They just slap that on because they knew there was a pool of patients there. So we're going through CHAD or a local group, which may have local referrals of people with expertise, can be helpful. The other thing I would say is that life is more about whether you get back on track than about whether you get off track. Everyone gets off track at least some of the time. People with ADHD do get off track more of the time. But again, the issue isn't to lament, beat yourself up, give up because you've gotten off track. It's how do you get back on track and restart making calls and connections? So unfortunately, the system does place barriers in the way. Again, other than persistence separate from asking for your insurer to help you, if you're really having trouble or stuck, maybe asking family friend, either or relative or spouse or kids or children or parents to help with reaching out to providers if that seems a daunting task, or you're getting off track, or you need just to be reminded to keep working on it. So if there's other angles of that question, Larry, let me know. The other, I'd say, bigger framing is that ADHD, as far as we can tell, for pretty much most people, is a lifetime condition. Not that getting into treatment sooner, the sooner you get help, the sooner, more likely it's to be of benefit. But the ADHD is probably not going to be going away. So whenever you get there, that's probably a good. And yes, it's unfortunate. It might take longer time than you anticipated or hoped for. So now I'm going to try to read through some of the more recent questions. Okay, I'm missing some. So James Alexander asks, in respect to the video on testosterone and ADHD, can long-term testosterone supplementation through injections, dermal gels, and so on eventually permanently lower your natural production of testosterone even after stopping supplementation? So I'm not sure how rigorously it's been studied, but yes, I'm clearly acutely. So while you are taking external testosterone, testosterone's involved in feedback loops, the production of it is. And in general, if you are taking a lot, particularly, that will shut down or feedback to prevent your own body from making testosterone. If you're taking a big enough dose, then that may be that may well compensate or even overcompensate for what your body's no longer making. And there are at least some individuals who, even when they stopped external testosterone, their body did not, at least quickly or within a reasonable period of time, jump back into making testosterone. So I guess the more important question is, rather than can it happen, is how prevalent that is when someone's taking exogenous, external source of testosterone. How commonly does that permanently lower or completely shut off your natural production? I don't know that we have good studies on that, and I just don't know what the studies we might have suggest or indicate in terms of how common that is. Hello again, Sleiman asks, which is worse long-term, low dose in terms of for anxiety antipsychotics or low dose benzodiazepines? So I'd say embedded in that is two different questions. One is, in general, what is the rate of long-term problems with either of those? And then more specifically, what is an individual's response? So there are people who are on long-term antipsychotics without problems. There are some people who are on long-term benzodiazepines, long-term without major problems. In general, the benzodiazepines have a very high rate of developing tolerance. So the majority of people do either need to escalate their dose or do get less benefit than they did previously, which is why they are generally not recommended for long-term use. Additional side effects, I mean, the benzodiazepines can cause sedation, they can cause discoordination. So particularly in the elderly, there's dozens of studies looking at the rates of falling and breaking a bone are much higher, both clinically and statistically elevated risk if you're on chronic benzodiazepines. With antipsychotics, from my point of view, the problematic side effects are metabolic issues where people gain weight and process fats and sugars differently, so higher rates of diabetes, higher rates of dyslipidemias. That risk does seem to be higher at higher doses and low doses, but there's not been any systematic studies that I'm aware of examining what is the risk or how high is it at low doses that might be used for anxiety. And then the other long-term bad risk with the antipsychotics is movement disorders. And that very clearly is a cumulative risk that the longer you're on the drugs and the bigger the dose, the more the risk there. So that in terms of cumulative dosage is maybe more of an issue with the antipsychotic than the benzodiazepine. But the bottom line is, again, how it's interacting with any given individual's body. So Mr. AKA asks, how can you tell if a stimulant is making you quieter and less social because of improved self-regulation or too much emotional blunting and overfocus? So I'd say some of that is probably best sorted out by the individual, hopefully with maybe a skillful therapist or psychiatrist asking questions to elicit. I mean, one would be to compare how extensively being quiet and less social is in different social interactions, sort of sussing out what the internal processing is. Are you sort of thinking of saying something and then not saying it because you're aware it might hurt someone or come across as strange or X, Y, or Z? I'd say most of the time, emotional blunting is a more commonly self-described problem with the SSRIs than with these stimulants. Certainly it can happen on the stimulants, but I'd say when someone feels emotionally blunted, their usual description is that both good things and bad things feel less intense. They just feel less connected to their emotions. Again, with depression, a small amount of emotional blunting, and I would describe it as more distancing, that someone feels less overwhelmed every time something sad comes up, that they can look at it, evaluate it, and decide whether or not to feel that sad. So my experience, and maybe I'm more careful with dosing medications, is that more often if someone's quieter and less socially interactive on their medication, on their stimulant medication specifically, it's more often through improved self-regulation. But it certainly could come from either those sources. So Max asks, why is atypical depression not its own condition or lumped in with another condition? For example, a lot of the symptoms resemble ADHD. Couldn't be called atypical ADHD instead? So part of it is, again, we have sort of a fossilized diagnostic system. So I'll back up a step, and I'm cheating and looking at the AI definition, but atypical depression is a subtype of depression characterized by mood reactivity to positive events. So rather than just being flat or irritable or numbed out or sad, someone's able to respond well to a positive event, along with specific symptoms like increased appetite or weight gain, hypersomnia, so sleeping more rather than insomnia, leaden paralysis, and rejection sensitivity. So I'd say the fundamental piece is that the core of atypical depression, and how we define what the core is or not is somewhat subjective or skewed, but that it seems to be primarily a mood issue rather than a attention focus executive function issue. So that's why it's being considered or lumped with depression. Two, in terms of treatment, most of the medications that treat depression, classic melancholic depressions, also do seem to be at least of some help with atypical depression. There was a more basic, important point that I was going to get at. Treatment response, core symptoms. Oh, why it's not considered its own separate condition. I mean, the DSM, for all of its faults and weaknesses, does require some amount of documentation of distinctiveness and excessive testing and some scientific consensus before something gets broken off. So even though it might seem arbitrary or subjective, they try to maintain some objectivity, particularly when establishing new conditions. So James Alexander asks, for my ADHD patients who have benefited from modafinil and armodafinil, were the doses that worked for them at the top of the dosage range, 400 and 200, or did the lower dosages tend to work too? So I've seen people who responded across the dosage range, and one of the people that comes to mind is one of the first people, and they had been self-treating themselves with it before they came to me. They were taking just 25 milligrams of modafinil and insisted that it worked better for them than any dose of Ritalin or Adderall they had tried. And I worked with that individual for several years, and they remained at that dose and felt that that was effective. I'd say more often the dosages that I've seen substantially working for ADHD have been in the same range that modafinil and armodafinil are recommended for other uses. So that's approximately in the 100 to 400 range for modafinil and the 50 to 250 range for armodafinil. And I'd say probably most often what I've seen helpful is sort of in the middle to upper half of that range, but there's a broad feedback or broad range, feedback. I'm jumping to the next question. So Max has provided the link to the Reddit thread. So again, next week I won't be here for anyone who's just checking in now. But any feedback about the channel is welcome there. And then Mr. AKA asked, how common is selegiline patch prescribed for depression? Sam Bakeman-Fried was on it for a decade for depression, but some people argued he was abusing it. So I know that, again, total sales of all MAO inhibitors have been less than 1% of the depression market every year since the 70s. So, and selegiline is just, its sales are pretty small in terms of the potential market part of it. And yes, a patch technology for depression sort of makes it unique. And there are some research and development costs involved in that. But my recollection is that it was priced pretty expensively, if I can talk long. Yeah, so the good RX patch, and I think this is for a month of the MSAM patch, it's about $2,700 for a month. So about $90 each patch. Is that right? I think I did the math right. It says with coupons, it can be as little as $2,000 a month. So part of, again, I think pharmaceutical companies should be involved in research. They should be being, I mean, they do budget for those research costs, and no, the research costs, to my mind, do not seem to be justified by excessive costs at that level. So again, part of it is they went for the strategy of let's corner a tiny market and make a huge profit on each one they sell, and rather than making it more widely affordable and available. And again, the MSAM patch, because it avoids that first pass metabolism through the liver and less. Um, so MAO in the brain winds up being targeted more specifically than in the liver. So it reduces the risk of tyramine problems. It also reduces the risk of serotonin syndrome problems to some extent. I was unaware of the claims that Sam Bankman-Fried was using it for depression, and I'm not clear, again, because and how you could be abusing it, or again, theoretically, it should be treating ADHD and other conditions as well, whether that's an off-topic use or whether that's abuse. So James Alexander writes that many ADHD, sorry, I'm jumping around. Many ADHD patients write online after being diagnosed, treated, and as adult that their childhood experience of having their parents avoid getting them diagnosed, ignore their diagnosis, or deny them treatment has motivated them to make sure that their children get the treatment they need. In contrast, have you heard of any patients where they began thinking or acting more selfishly after their adult ADHD diagnosis treatment out of belief that they deserve to make up for their lost time and experiences in life? Yeah, I'm not sure that I would even identify selfish. I mean, the contrast. So I'll back up. I'd say part of why parents might not seek treatment for their kids with ADHD are twofold. Both focusing on ADHD has a strong hereditary component. So it could be that the parent sees some of the symptoms they have in their own kids and therefore normalize it and therefore minimize the severity of it, or think I dealt with this, therefore this kid should be able to deal with it as well. Um, so that's separate from ADHD itself, and the parent could lead to sort of obliviousness and not even being aware that their kid is the one who showed up 3 days this week without a lunch because parent forgot to pack it, and the kid adapted by having other kids share lunch, or the school teachers or lunch monitor help make sure that happens. So it never reached the parents' awareness or penetrated partly because of their own ADHD. So there's two components there that can make. So that doesn't necessarily mean the parents were acting selfishly. It's unfortunate, but a third element that I would put in there, and some of this is best exemplified by the New Zealand Dunedin study, but numerous other studies, even kids who are not just treated and evaluated for ADHD, but who are enrolled in studies that are asking about it and investigating it, a substantial minority, and it's a pretty big chunk depending on the study, 20, 30, 40% of kids who were clearly diagnosed and treated as youngsters, as young adults, don't have any recollection of that and claim that they weren't, even though, again, when it's documented. So I'm not saying that's the majority of these cases. I'm not saying neglect, missing it are not. I think they are common, but there's also, again, an element of some of that is being over-reported by people who don't recall their own treatment. So more getting around to James Alexander's sort of question, do I see people behaving more selfishly after their own diagnosis to make up for time? I would say I've seen people behave more, I'd say, appropriately assertively. So a common saying among people I've worked with, and one person in particular, but I've heard others say it, is that they were such a doormat during their lives that because of their ADHD, people took advantage of them in negotiations and interactions, that they were used, that they were, they were the one that volunteered first because something sounded exciting and everyone else, could think of why it would be a lot of work and they didn't initially. So I have seen people be what I would consider more appropriately asserting their own value of their own time and their own energy and trying to marshal it and take care of it better. That's how I would frame it. So Steve is commenting they have Kaiser and Medi-Cal. I'm not seeing a question there. Maybe there's. So Max is forwarding a Reddit question, and I today do have to finish right at the hour. So designer study says, I feel like inattentive ADHD has more underdevelopment of the right brain hemisphere compared to hyperactive ADHD. And I think this could also explain why inattentive ADHD seems to share more overlap with autism and schizophrenia compared to hyperactive ADD. What do I think about this? I would keep it fairly simple, and I think there's a kernel or element of validity to that observation. So James Alexander asks, as a trained neuroscientist, if I had to guess, would I say that the oxidative stress imposed on the average ADD patient's brain from an extended release stimulant like Vyvanse is greater or lesser than that of 24/7 acting selective norepinephrine reuptake inhibitor like Strattera? Yeah, I guess I'm not. Sorry, I won't try to speculate because I think some of that should be fairly measurable and ascertainable, and I just don't have the data at my fingertips as to what I'm on. I don't know that it's been studied extensively, but to me, there's not much point in my speculating what I would guess or think, given that that's a simple, testable. It's a good question to be asking. Well, I'd say oxidative stress or load is also something that occurs on a spectrum. Some amount of it is manageable and normal, and some amount of it, when it's too great, can lead to toxicity and problems. I guess the fact that we're so far not seeing massive signs of pervasive brain deterioration due to excessive oxidative stress in either people long-term on stimulants or long-term on norepinephrine reuptake agents. Maybe the whole question is more academic or minor, or it might turn out that there are subsets or populations where it's important. So that. So James Alexander is sort of following up that there's a popular perception among ADHD patients that stimulants are more potentially neurotoxic long-term in theory than SNRIs, since they boost up your dopamine more across more areas of your brain. So I do have a talk about the harms of, do stimulants damage your brain? And part of the concern is that street stimulants, which are causing a bigger flood and a quicker flood of dopamine. And we know that it's not just the total amount of dopamine boosting, it's how quickly that's happening can saturate the capacity of systems to protect the brain. So we know that street stimulants can damage the brain. We know that from animal models. We know that from human examples. But again, the specific agent, the dosage, the delivery system, the one other important factor, pattern of use and general health of the individual involved are also potential factors there. So there's sort of more animal-based or theoretical reason to be concerned. But again, so far, therapeutic dosages of stimulants don't seem to be replicating damage like can be seen in animal models. On the other hand, the SSRIs and the SNRIs have been shown to have some neuroprotective effects, specifically boosting brain-derived neurotrophic factors and others, brain nourishing or supporting chemicals, actually promoting new nerve cell generation in the hippocampus. There's at least one study suggesting that long-term stimulants may actually be neuroprotective in an ADD setting. Different people interpret that study differently. There. So Steve asks, I thought MAOIs can be verifiably dangerous. They interact with everything in major ways. So many drug ads warn not to mix with an MAOI. Generally, MAOIs are last resort for depression. So again, I go into some of this in that. So two big problems with the MAOIs. They can interact with, and it's mostly foods that contain tyramine, and the tyramine can cause blood rush. And it's tyramine interacting with norepinephrine can cause blood pressure spikes, in the 180 to 220 range, so that people are actually in danger of causing bleeds or strokes or even death. To my knowledge, no death has happened from an MIO from tyramine crisis in a few decades, but some did occur in the 50s and 60s. So that risk seems to be smaller than was advertised in terms of, one, lots of foods thought to contain tyramine don't. One is that some things like raspberries wound up on the list because someone who ate raspberries and some other foods in a meal, and probably something else in the meal had high tyramine, had a hypertensive crisis, but the diligent doctor reported everything that was in the meal. And in this age of cover your butt medicine, once something dangerous is on a list, everyone else is afraid to admit it, because what if a second person 6 years from now eats raspberries and has a problem? What if it really is involved? So clearly lots of things, foods that wound up on the lists never were probably likely containing much tyramine. It also is tied into, until moderately recently, the assays for testing for tyramine weren't terribly accurate or readily available. Two is that for many foods, including some of the fermented cheeses, sausages, alcoholic beverages, the tyramine wasn't an intrinsic part of that ripening, aging, fermenting product, making a new product. For some it is, but for others, it was a result of concomitant, co-occurring bacterial contamination that wasn't making the flavor more flavorful or developing the product. And modern industrialized food processing techniques have eliminated tyramine from some foods because of that. So that's a tyramine issue. The other issue is a serotonin syndrome issue. And again, MAOs can boost serotonin. Other drugs that boost serotonin, the two together make it more dangerous. So to put it in perspective, one, serotonin syndrome exists across a spectrum of severity. So at its most extreme, it can cause hyperagitation, excessive sweating, tremors, seizures, death. That's horrible. But the vast majority of cases of serotonin syndrome are much milder and not particularly serious and short term. The risks with the MAOIs is that one, particularly the irreversible ones, is that they can inactivate that enzyme for 2 weeks after you've stopped taking it. So there's many both case examples and systematic studies, for example, using stimulants with MAOIs and bipolar depression. There's a couple different studies showing that can be done safely in many people. But there is a general warning that don't just blindly combine these two drugs because there is a potential risk. I mean, the other thing is there is a range of susceptibility both to serotonin syndrome and to tyramine reactions. So yes, the warning is in there usually appropriately, but I think we scare lots of people away who could use these drugs safely and effectively. So James Alexander asked, do you think just a week of testosterone replacement therapy is enough to permanently trigger natural production shutdown in those susceptible to permanently lowered testosterone production? I would be surprised. I mean, in a normally functioning system, you would not think that a week of replacement therapy, even at a really big dose, would permanently trigger it. But my guess is most people who are using it don't have a normal system to begin with. So maybe there is something already impaired. So I wouldn't rule out it being impossible. I would put it in the realm of, again, without my being aware of the specific data, I would have a very low level of concern that a week of replacement on testosterone is going to permanently shut down testosterone production. So, Michael, thanks. I actually was debating which shirt to wear today. I wore this. This was next up on my coat rack or hanger of shirts. And because I'm not going to be here next week, I did bring the legendary green shirt. Wasn't aware that people were noticing that closely. And it is getting old and frayed around the collar, so maybe I need to get a new favorite green shirt. James Alexander asks, have there been any changes in the DSM that I have disagreed with? I think I'm trying to think of any off the top. I mean, my bigger objections are it hasn't changed enough and that more fundamental major changes need to be made. So I'm trying to think of changes that went too far or were inappropriate. Again, I think they tend to be, particularly in the last 3 decades, fairly careful and feel that they have to have a substantial amount of information before they make a change. So again, I think it's more, I'll write that down. I can't think of anything offhand that they went too far or went overboard or went too fast. So James Alexander asks in one of the last Q&As, I mentioned that Dr. Russell Barkley is more willing to take on important stands like questioning the effectiveness of neuropsychological testing. Are there any other important stands he takes that others are more quiet on? And there I'll just have to feign ignorance. So again, I respect him. I like the work he's done over the years. I like his willingness to speak up, but I think I've only watched 2 or 3 of his videos. So I don't even know. One of them was on his commentary about the Peter Tuff, the New York Times Magazine article about ADHD. So I spend very little time listening or watching YouTube videos or other forums where people might be speaking out, and try to spend more time writing and talking my own and doing my writing and doing my own research on the basic research. So I am sure there will be others that if I had paid attention, I would be aware of. So Schleiman is asking, which is better for depression, agitation caused by stimulants, valproate or lamictal? And again, my answer there would be that a specific individual is fairly likely to have moderately different responses to stimulants, Depakote, valproate, or lamictal, lamotrigine. So what works well for the individual may be very different than what the general record show. All of these are sort of, lamictal's been approved for bipolar depression. It's not been approved for unipolar depression. In general, other than dangerous rashes, lamictal is the least likely to add in unwelcome side effects among that group of agents. I'll just cut that. That's how I'll answer that. Sorry. So Zerbong 420 said, my mother gave me ADHD genetically. Can I give it to my girlfriend? And if not, what is her excuse to be the way she is? So I think that there's an element of humor intended here. Maybe not. I hope I'm not over. So I do have a video on how much ADHD affects the mates we seek out, and whether there's people with ADHD tend to seek out other people with ADHD. I think that's certainly a pattern that shows up. There's certainly other people with ADHD who tend to do best and seek out people who have as little ADHD as possible. There may be aspects of engaging in activities that are thrill-taking or high energy, high stimulation that maybe you met in an environment that is co-selecting for ADHD itself. So that's how I'd answer that. Mark asks, what motivates me to take the time out of my life to do these weekly live streams? I answer that. I don't view it as time out of my life. It's time in my life. And this might seem weird, why I went into medicine is, my thought is, why I'm here on Earth, and hopefully why most of us are here on Earth, is to make lives better. And my thought is I can have a fairly large impact on maybe family members, maybe dozens or even hundreds of patients, but a fairly small number. And for me, since I have some abilities, and I think they really are better in the written realm to explain things, and that I can understand things at levels that maybe others just don't have that knowledge or training or expertise. So part of it is to help a lot of people a tiny bit, and a few people a small amount. And that's how I frame that this is, I'm glad for the opportunity to do it. I hope even more people can take advantage of the opportunity that haven't heard of this already. That's where I'm coming from. So James Alexander asks, have I ever been reluctant to prescribe a specific medication that a patient wanted? If so, why were we reluctant? Likewise, have you ever run into stimulant-seeking patients some psychiatrists warn about? So one is, I've had people come in asking for brand name products, and so it's often discussions of the differences or lack of differences with the generics has come up. And two is, among SSRIs, Paxil was fairly widely and effectively marketed, and at a basic level, it's not that different than the other SSRIs, but on a specific level, it is, study after study, slightly more likely to have sexual side effects, nausea, more problems with withdrawal. So I think it is a lousy option when you have similar options to start people on. I've had people who've done well for it. I've had people who've had really bad issues with it. So I don't think it's an evil medicine or a horrible one, but I think in that case, if someone came to me asking for Paxil, paroxetine, I would sort of explore why. Have I had stimulant-seeking patients, some psychiatrists warn about? So part of my excessive interest or attention to amphetamine-induced psychosis is I've had several patients who came in, provided compelling and convincing, not just history of ADHD, but presented it in the session. And I would argue it's actually hard to act out, even if you're a professional actor. We can get into that at another time. So people who clearly had ADHD, but people who had had previous amphetamine-induced psychoses and were seeking to get it again, but lied about their history. So that's the biggest scenario, and it's not been a lot over the years. It's just very alarming when you know you've been tricked into providing a medication that has harmed someone before, and usually you don't find out till it harms them again. So in general, I don't see lots of healthy, happy Silicon Valley coders or college students who have not. So I believe the evidence is compelling. Lots of people are on the ADHD spectrum, whether or not they have full-blown clinical ADHD, and the evidence is overwhelming that medications and other non-medication treatments that work for full-blown clinical ADHD also usually work for less severe cases. So that's how I'd answer that. So Nick is thanking me for the videos. He's taking for Cymbalta for OCD and anxiety, and it's working well. Wants to know whether it makes sense to use atomoxetine alongside of it for ADHD symptoms, since they have an interaction of approximately the same binding affinity to norepinephrine. So my first question or issue there, and again, I'm not making a specific recommendation. My first thought is, if someone's on an agent like Cymbalta and getting some good results, but hoping for more, particularly from the norepinephrine reuptake range, it's usually to consider increasing the dosage of Cymbalta first before adding a second agent like atomoxetine. But I do have people who are on the combination of the two. If it's specifically more norepinephrine and not boosting more serotonin that works for you, that might work. It may also be that milnacipran, which is an SNRI that's more skewed towards norepinephrine, may be a good fit. So do I have birds as pets? No, the birds you're hearing are mostly northern cardinals, which are a mainland species not native to Hawaii, that are maybe the trees are 30, 40 feet from the window here, but they're loud. There's no traffic or other things to block or mute the sound. So Max, thanks, brought up the video on ADHD and seeking romance. I need to end for today, so so James Alexander, I have a video on this as to whether Ritalin makes sense to be classified as a stimulant rather than a non-stimulant. Max is reminding people that I won't be here next week, but there's a redirecting people to Reddit for feedback on this channel. So stay healthy, stay happy, have a good 2 weeks, and I'll be back then. So thanks for the questions, and thanks for the thought you put into those and the appreciation you show.